The title of my talk is Robotic Assisted Knee Arthroplasty, and we're going to look at using technology to improve outcomes. So just a little bit about myself. I'm a knee and shoulder specialist with TOC, and I practice at 2 locations primarily, at TOC at Fort Sanders Regional, and then also at our Sevierville office. I have no financial disclosures and don't receive any funding from any implant companies. So just a little overview of what we're going to be talking about. We're going to look at understanding joint pain, look at treatment options, look at joint replacement surgery, recovery expectations, and then have some time for question and answers. Your joints are involved in almost every activity you do, and as many of you know, a diseased knee can really significantly limit your ability to move and work. So what are the common causes of joint pain? First and most common, and one of the most common things I see, is osteoarthritis, which is your general wear and tear arthritis. And it's when the cushioning cartilage at the ends of the bones wears down, making walking painful as bone rubs against bone. Another common cause of joint pain is rheumatoid arthritis, or sometimes called inflammatory arthritis. And this is a condition in which your own immune system attacks the joints with uncontrolled inflammation, which potentially causes joint erosion. And lastly, post-traumatic arthritis, which is less common, is when a fractured bone or broken bone extends into the joint space, which can cause the surface of the joints to become uneven. And over time, this friction can cause the joint to break down and become arthritic. So looking at knee anatomy, there's really 3 main bones that make up the knee. You have your femur or your thigh bone, the tibia or the shin bone, and then the kneecap. On the ends of each of these bones, you have the smooth gliding type surface, which is shown in white, which is the cartilage. This is what really allows for good range of motion in the knee. And what arthritis affects is really the cartilage. So as the cartilage starts to deteriorate, that's when these surfaces become irregular, causing more pain and inflammation. So what are some of the treatment options for arthritis? So certainly starting with our non-surgical treatment options, over-the-counter or prescription anti-inflammatory medicines are a very easy thing that many patients use and have good success with. Physical therapy can help strengthen the muscles around the knee to help compensate for some of the arthritis. You can offload the joint through use of assistive devices such as a cane or a walker, or weight loss also can help take off pressure through the joint. Local modalities such as heat, ice, or cream sometimes can be effective as well. And then finally, injections. There's 2 main types that we primarily use. One is a steroid injection or cortisone shot, and the other is a gel type injection, which is made up of hyaluronic acid, a normal substance which is in the joint that helps lubricate the joint. So when do we consider moving to joint replacement? And I tell many of my patients this really is a decision they make more so than I do. They know when they're ready and they've really failed the other options that it's time. Some of the questions that to ask yourself when you're ready is joint pain affecting your ability to get a good night's sleep? Does joint pain keep you from doing things you want to do? Are you less active because of joint pain? And is joint pain affecting your ability to walk upstairs? And you could also add in, have you failed the other measures that are non-operative? So what are the goals of a knee replacement? First and foremost is pain relief. Really, over 90% of people experience a significant reduction in pain following joint replacement surgery. So fairly good outcomes. And then second is to improve function. It's getting people back to the activities that they love and enjoy, such as walking, driving, biking, swimming, golfing, or dancing. So what is involved in a total knee replacement? How does it all work? So this is a little short video showing exactly what is replaced when you do knee replacement surgery. So really what we're trying to do is really just resurface the ends of the bones to remove the diseased cartilage so that you can place the implants. So there's a metal piece that goes on the end of the thigh bone. There's a small tray that goes into the top of the shin bone, and then there's a plastic insert in between the joints. This creates a new gliding surface, so instead of bone rubbing on bone, you have the metal on the plastic. What makes a knee replacement successful? There's a couple key factors. Number one is to restore normal limb alignment. So most people either fall into being more bow-legged or varus, or being more knock-kneed, and this puts pressure on different areas of the joints. So our goal is to restore it back to a more normal alignment so that the pressure forces on the knee can be distributed evenly. So if you had a knee like this, which is more knock-kneed and has significant bone-on-bone arthritis in the lateral side of the knee or the outside part of the knee, then with a replacement, you can straighten this back out. We also want to create a stable knee with good soft tissue tension throughout a range of motion. This is a video of one of my patients at 2 weeks post-operatively. You can see he still has a little bit of swelling and some bruising, but you can see that he's got a stable knee with great range of motion. He extends very easily and can flex his knee very easily. So why do I use robotic assistance? I feel this helps to really give me better accuracy and precision. So if you can use the analogy of shooting at a target for a bullseye, it helps to eliminate those outliers that aren't right in the center. It produces more of a consistent result every time. It also allows me to protect the soft tissues and the ligaments better than the manual techniques. So you can be more protective of the ligaments around the knee so that the knee is stable. It also allows to cut less bone than some of the manual techniques from before so that you can preserve good bone. I also find that patients have significantly less pain with robotic assistance than they did before. So how does it all work? This is a short video just showing some of the demonstration of the process. So this is the actual robotic arm shown here. So in terms of treatment with this, the first step in all of this is we get a CT scan, as they're showing here. A CT scan is just a series of x-rays at different angles, and this helps us to create a three-dimensional image of the knee. So we take all this together and create a three-dimensional virtual model. This allows us to then develop a preoperative plan for the knee and how it should sit. So this helps us with sizing, as well as how the implants should sit in the knee. So we review the preoperative plan before, make any adjustments so that it fits perfectly. The next step is during the surgery, we then register the anatomy of the knee using a little probe. And I'll show this in the video in just a second with me doing this, so that it registers that to the 3D model. This tells the robotic arm exactly where the knee is in space. Next, we can assess the range of motion of the knee during the surgery and also assess the tension on the ligaments. This allows any small adjustments to the preoperative plan so that we can then, lock that in. At this point, then we're ready to remove the arthritic bone and make cuts. As you can see, I'm controlling the robotic arm, but there are boundaries to where I can cut. There's also, on the screen, as you see, you can see there's guidance for me so that I see that green, so I know exactly where I'm cutting and how much bone I'm removing. And it only allows me to cut within that plane. Once all the cuts are made, we then place the implants. And then once that's finished, it's off to the recovery room. And then the real process really begins in terms of the recovery. Just to review, and I'll show some videos of myself, we have a personalized surgical plan based on a CT scan. Then during the operation, I register the points on the knee to the 3D model. You can see the foot is down at the left and the patient's head would be at the top, right. Next, I then take the knee through a range of motion and I assess the soft tissue tension on the knee. And then I can make any adjustments to the plan that I need before cutting the bone. This really allows us to make it very stable and personalized to each person. So then you can see, as I'm doing here, I'm controlling the robotic arm once I've locked in the plan to remove the bone. And I'm using the screen with the green to show that exactly how much I need to remove and once it's all completed. Once all the cuts are made, the implants are then placed. We then reassess the range of motion and then it's off to the recovery room. So in terms of the recovery from knee replacement, it's generally either an outpatient surgery or a one-night stay in the hospital. I would say about 33% or a third go home the same day. Begin physical therapy 2 to 3 times per week, working on knee range of motion and walking and getting back to daily activities. This takes about 3 to 6 weeks to return to daily activities. And then the total recovery is about 3 to 6 months. I see the patients at 2 weeks, 6 weeks, 3 months, and at 1 year if needed. So just a few outcome studies looking at robotic assistance. The first study on the left, they compared robotic assisted total knees to conventional knee arthroplasty. They did 40 one way and then did 40 the next way. In the robotic assisted, they showed decreased pain and a quicker time to discharge with the robotic assistance. The second study, they looked at how much damage was caused by each method, and they showed less bone and soft tissue damage with robotic assistance. And this is something I've found to be true in my own practice as well. So at this point, I'm going to open it up for any questions. Also just show that if there's any later questions, if someone's watching this not live, I do have an email address that they can address some questions to me. And there's also a website that also just shows some more about robotic assisted knee replacement. So I'm going to look and see if I can see the box for the questions.
Dr. Jaquith, did you see Carolyn Greenwood?
I do. So
okay,
our first question is from Carolyn, and thanks for your question. It says that it seems that the process of doing a knee replacement keeps getting less invasive and recovery time keeps getting shorter. I don't think I need this yet, but probably will within about 10 years. I am 63. Are there additional new procedures in the works that might be a reason for me to wait a little longer rather than doing this sooner? So in terms of this, I would think that, she may be asking about things like stem cells or other things that are out there. At this current time, we don't have any really good options for regrowing new cartilage. I don't think that's going to be the next 5 to 10 years in terms of a less invasive type thing, in terms of just injecting something in the knee. There are other potential options such as partial knee replacement, which is slightly less invasive and might be a good option, which also can use robotic assistance. But I haven't really seen much great success from any of these stem cells or injections that aren't the things that I mentioned. And our next question, this is from Janet Roberts, and thanks for your question. She says, at what hospital do you perform your surgeries? So in terms of the robotic knee replacement, I perform that at Fort Sanders Regional Hospital. I see patients at 2 locations, but that's the main site where I perform surgery. And we also have other physicians within our practice. If someone is, further away and that also performs similar type procedure, robotic assisted knee replacements at our other hospitals, Park West and Methodist. So there are some other options as well. Our next question is from DF Payne. It says, I am 56 and need total knee replacement. How long will it last? How hard is it to have another one? Very good question. So most of the studies indicate that knee replacements are lasting 20 to 25 years in people that are in probably about 90% of the patients. So unless you had some type of complication, such as an infection or a fracture or something, that happened out of the ordinary, hopefully it would be fairly easy and last the rest of your lifetime. But in terms of how hard it is to have another one, it depends on the need for the second knee replacement. So if it was just exchanging the plastic liner, if that's the only thing that's worn out, that's fairly easy in comparison to the original surgery. If you needed more of a revision for infection or another reason, that can be sometimes hard. And the recovery is similar in terms of the timing as well. Another good question, Janet Roberts asked about what is partial knee replacement. So instead of replacing the entire knee, there are partial replacements for people if they only had isolated cartilage damage in one area of the knee. So if it was, for instance, just behind the kneecap or just on the inside part of the knee and the rest of the knee is very pristine, then that can be an option, and sometimes that's a faster replacement. You're just replacing what you need in that instance. And then I have another question. It's from Amy Hemkin. And she said, what material are the implants made from? Generally, the femoral component and the tibia component, so the piece that goes on the end of the thigh bone and the top of the shin bone, are both made out of titanium generally. And then the plastic is made out of a highly cross-linked polyethylene. It's just a highly advanced plastic.
I think that is all of our questions so far in the chat box. Does anyone have any to wrap us up? Anybody at all? If not, that will conclude our presentation for the day. I'll be sending out an email including the recorded version of this and also a link to schedule with Dr. Jaquith. And if you have any other questions, you can